Our second lecture in the three-part series on mental health issues in older people will focus on dementia in the emergency department. We will look at the definition of dementia, screening for dementia, and then talk a little bit about dementia in the emergency department. So dementia is a chronic illness characterized by short-term memory loss of sufficient severity to interfere with function, and one of the following: apraxia, which is difficulty executing motor tasks; aphasia, any language impairment, often word finding; agnosia, difficulty recognizing familiar objects; and loss of executive functioning. Before we proceed, I just want you to think a little bit about the implications of these clinical features of dementia on our consultation with a patient with dementia in the emergency department. Often we find these patients difficult, but it may be that we are just not dealing effectively with their clinical features. For example, when examining a patient with dementia, we may find that they are not cooperating with us and doing what they want us to do, we want them to do. But this may just be a manifestation of apraxia. Similarly, we may be talking to them and they do not seem to understand what we're saying. Again, this may simply be aphasia. Or when discharge planning, we may explain to the patient what needs to be done, but if they have dementia, they may not understand what we are saying, or they may not be able to process complicated instructions because of a loss of executive functioning. Why do patients with dementia present to the emergency department? Patients with unrecognized dementia may present with accidental injuries. And if we see an older person with repeated accidental injuries, we need to think about the possibility of cognitive impairment and dementia. They may lose track of their medication and are at risk of self-poisoning on either prescription or over-the-counter medications. They may present with behavioral issues such as aggression, paranoia, confusion, or disinhibition, and they may be brought because friends or relatives recognize that they have cognitive impairment and are concerned. A good rule of thumb, not to be taken completely seriously, is that if somebody presents telling you they think they have dementia, they probably don't. But if somebody is brought by relatives or the relatives are telling you they think this patient has dementia, they probably do. One screening test for dementia is a mini-cog assessment. This consists of 3 parts: instructing the patient to repeat and then remember 3 unrelated words, then giving them a piece of paper to draw a clock with a specific time on it, and then finally asking them to repeat the 3 words previously presented. The scoring system goes from 1 to 3 as outlined on this slide. 3 indicates a negative screen for dementia. If the patient has a score of 0 to 2, they need further assessment. How does undetected dementia impact on the patient in the emergency department? Remember, if you don't know that somebody has dementia, you may have difficulty gathering information from them. They may give a poor or misleading history or be vague about their presentation. You may think you are getting informed consent for invasive or risky procedures, but clearly if the patient has cognitive impairment, they may not be able to give properly informed consent. And if you don't know that they have this problem, you will be unaware of this fact. And finally, if your patient has cognitive impairment or dementia and you are planning their discharge, you may be giving them lots of information, but they will not be able to process it. So you can see why knowing that your patient has cognitive impairment or dementia helps with the planning of treatment. Why do these people present to the emergency department? Well, often because they have dementia and then it deteriorates acutely. We need to think about why this might happen, and the reasons for acute deterioration of dementia in older people with dementia is similar to the reasons for delirium. Uncontrolled systemic illness such as diabetes, hypertension, other endocrine disorders such as hypothyroidism. Infection causes acute deterioration of dementia in older people. Polypharmacy, or the addition of new drugs, may impair cognitive function and worsen dementia. Similarly, other psychiatric illnesses such as undiagnosed schizophrenia may make dementia worse. And specifically, depression on top of dementia tends to worsen both illnesses, bearing in mind that depression and dementia have a great overlap in symptoms, as we will discuss further in the third lecture in this series. And finally, loss of independence or loss of functioning can worsen dementia in older people. Finally, we need to think about what a safe discharge looks like in an older person with dementia, and this mnemonic helps us to assess for certain specific risk factors. So the mnemonic is risks, and it helps us to remember to think about the risk of roaming or wandering, any imminent danger such as the danger of falls at home or fire setting in the kitchen, suicidal ideation, kinship or relationships, particularly thinking about elder abuse or inadequate social support, and finally, safe driving, substance misuse or self-neglect. If you have any questions about this brief presentation, please feel free to post these on the WhatsApp group or on the TEMA website, and we'll try to get back to you. In summary, dementia is common in the elderly. Screening is important in all older patients, but particularly in specific circumstances, and early recognition in the ED can be helpful to improve management and outcomes. Our final lecture in this series will discuss dementia in older people.